All right, it is just 12 o'clock, so we'll go ahead and get started. Welcome to Medical Grand Rounds at the University of Colorado. Thank you for all of you who are here in person in the Schroffel Auditorium. Please come and fill this place up, although we will continue to broadcast on Zoom for the rest of the year as well. Just as a little bit of a teaser, upcoming talks, next week on December 6th is Dr. Chopra giving the state of the department. We would really like to see all faculty members at that talk in particular to hear about how our Department of Medicine is doing. And then on December 13th, we will be Zoom only, so you do not have to come here on that day, but for one of our second quarter's Systems Improvement Conference. And as a reminder, you can use this QR code to get CME and MOC credit for all talks this year. Now, I am very pleased to welcome today's guest speaker coming to us from the University of Michigan, Dr. Mei-Lan Han. Dr. Han is a professor of medicine, and she's the chief of the Division of Pulmonary and Critical Care at the University of Michigan. She received her medical degree from the University of Washington in Seattle. She completed residency in internal medicine and a fellowship in pulmonary and critical care medicine at the University of Michigan. And she also completed a master's degree program in biostatistics and clinical study design at the University of Michigan School of Public Health. Her research is focused on defining phenotypes in COPD using advanced imaging methodologies. She's a lead investigator for several NIH-sponsored COPD studies. She also serves on the scientific advisory committees for both the COPD Foundation and the American Lung Association, and sits on the board of the COPD Foundation. She currently is the deputy editor for the American Journal of Respiratory and Critical Care Medicine, our Blue Journal, and serves on the editorial boards for Thorax, Lancet Respiratory Medicine, and the Journal of the COPD Foundation. She's also a member of the Global Obstructive Lung Disease Scientific Committee, which is charged with developing internationally recognized consensus statements on COPD diagnosis and management. And also, very interestingly, she is someone who has the ability not only to do all this incredible scientific work, but to speak to the lay community and the lay press, which she does frequently, including in a book she wrote recently entitled Breathing Lessons, A Doctor's Guide to Lung Health. It really is an honor to welcome you here to the University of Colorado. Dr. Han.
All right, can everybody hear me okay? I'm really bad with tech. Probably should have warned someone about that. All right. Well, it's a real pleasure to be here with all of you today. I was telling Jeff, I always love to get to do in-person talks. I get really tired of Zoom talks because I don't get to see everyone's lovely faces. So it's a huge privilege and honor to be here with all of you today. So I will apologize in advance. I heard from the chief residents last night that basic science lectures are preferred, but this is not a basic science lecture. So no cytokine pathway diagrams today, no ferret models, but rather the talk today was really kind of born out of sort of, I'm going to call it a self-reflection journey over the last couple of years. So I have been a spokesperson for the American Lung Association for a long time. And companion to that, I'm also very interested in lung health and trying to understand the origins of chronic lung diseases like COPD. And for a long time, pretty much nobody was interested in either. And my job at the American Lung Association was pretty sleepy. In the fall of 2019, suddenly there was a little bit more interest. Suddenly we were seeing things like vaping-induced lung injury, and all of a sudden people were like, gosh, maybe we shouldn't just breathe whatever into our lungs, and maybe it matters. And then in the spring of 2020, the COVID-19 pandemic hit. And suddenly everyone wanted to know how their lungs work, what is mechanical ventilation, et cetera, et cetera. So I had the fun opportunity of getting to do an episode of Freakonomics, explaining kind of the difference between positive and negative pressure breathing. And then after that, I actually was contacted by Norton Publishing and had the opportunity to write a book to explain to the public how their lungs work. But in the process of doing that, all of my, I do clinical research, all of my clinical trials were shut down. And so I had sort of this 12-week period or so during the summer of 2020 where I had a lot of time to think and to reflect. And it really bothered me, the huge impact that we were seeing from this respiratory pandemic, and how really honestly woefully underprepared we were, not just from an infrastructure standpoint, but from just even a treatment standpoint, or a basic understanding. Why does nobody understand how the lungs work? Why don't we have better treatments for ARDS, generally speaking? Why have there been so few investments? Why is this hitting us all as such a big surprise? So the talk today is sort of just kind of, me kind of doing more thinking and more research into that. And so I really kind of just wanted to share with you today some of what I've discovered. So I mentioned to you that at the beginning of 2020 is when this little story for today really starts. Like I said, the public was sort of wondering, what is a mechanical ventilator anyway? What does it do? What do we do about the shortage that we suddenly have? And unfortunately, we were also woefully off on the projected deaths. White House had projected 1 to 200,000 deaths. Now here we are into 2023. I checked the figures this morning, and we are still at a little over 1 million deaths here in the United States related to the COVID-19 pandemic. But if you're a lung doctor like me, and you do a little bit more digging, you'll know that the majority of those patients either died due to a primary respiratory cause or something that got triggered by respiratory failure. And in fact, in 2021, the American Lung Association, for the first time ever, determined that both when you combine acute and chronic lung disease together, that lung disease was actually the #1 cause of death in 2021. And so, as I mentioned, this really bothered me. Like, how did we get caught so woefully underprepared to deal with this pandemic? How did we end up here? And so I did a little bit of digging into the archives to try to figure out why the development, our modern understanding of lung disease and our ability to diagnose lung disease was so poor. So the first sort of advance in development of the closest thing we have to the modern day spirometer was a device that was invented by a gentleman named John Hutchinson back in the 1800s. And it was a big device. It was kind of clunky. Essentially, it was like an inverted bell on top of water, and patients would blow into it, and the amount of water displaced would give you this number that he called vital capacity. He was actually an assessor for an insurance company, and he figured out back in the 1800s that vital capacity was actually associated with mortality. And that's something we very much well know today, but somehow, somewhere along the way, we not only forgot that little bit of information, we sort of forgot about his device altogether. And in fact, John Hutchinson died in obscurity in Fiji under sort of unknown circumstances. And with it, the spirometer really kind of fell into obscurity for the next, roughly 200 years. But one of the things I was really, really curious about was why we do such a much better job screening for cardiac disease. Why have there been so many more advances for treatments for cardiac disease than there have been for pulmonary disease? And so I thought, okay, I understand kind of what happened with the spirometer. Why do we measure blood pressure? Why are I can never say it, sphygmometers ubiquitous in doctors' offices? And I think it's really a combination of two things. And as always, I think with everything, there's always a little bit of serendipity that plays into everything. For one thing, as you could see on the prior picture, the early spirometer was huge. And it was clunky, and you had to fill it with water. And there was no way that was going to easily fit into a doctor's bag. If you compare that to a blood pressure cuff stethoscope setup, you could easily fit that into a doctor's bag. You could take it into the home of a wealthy client. Now, you have to remember, in the early 1900s, medicine was not really evidence-based, right? This was an evidence-based medicine-free zone. Doctors essentially did whatever they thought made them look cool. And carrying in a blood pressure cuff and a stethoscope, particularly when you combine them together, you can get both systolic and diastolic measurements. it made them look cool. They had a skill set that distinguished them from, from all the snake oil charmers, et cetera, that were running around also trying to make money. And so doctors just really bought into the idea of getting a lot of blood pressure measurements. They really had no idea what it meant. But there were doctors that liked doing it, and we just started getting lots and lots of measurements. So in 1932, Franklin Delano Roosevelt was running for the US presidency. At that time, his blood pressure was recorded at 140/100. Kind of high based on today's standards, but at the time they had no clue. He actually chose an ENT physician as his primary physician going into the White House. And then over the next few years, if you look at his health records, his blood pressure continued to climb. So it was then recorded at 108/105 in 1941. And by 1944, when he was ultimately diagnosed with heart failure, it was around 300 and 100, over 190 around the time that he ultimately died from a stroke. But at the time, again, we really did not have a good understanding about the relationship between blood pressure and cardiovascular disease. Following on FDR's death, Congress funded the National Heart Act. The National Heart Act is what brought about Framingham, which I think probably most of us in the room are familiar with. Framingham is arguably one of the most important and successful epidemiologic studies that has ever really been conducted. The site was chosen because the citizens of Framingham, Massachusetts were willing, and the researchers at Harvard had ready access to this willing group of participants. So it made a lot of sense. Now, over time, this study has had multiple principal investigators. It's had multiple funding streams, including both NIH and private support. But when you look at sort of the successes that have come out of that, we now understand the importance of blood pressure. We understand the importance of obesity and cholesterol. And if you look at just all of the developments for treatments of cardiovascular disease over the last 50 to 70 years, there's just so many monumental successes, whether that's blood pressure medications, whether that's cholesterol medications, or PCI, other types of interventions. And what we've seen overall is a massive, dramatic reduction in cardiovascular deaths. So if you look at some of the top causes of death, you'll see we've made massive strides with respect to heart disease and stroke. Cancer has remained sort of steady. But on the other side of the panel, what do we see? We see this slow, steady uptick in deaths from chronic obstructive pulmonary disease, which arguably is the most common adult lung disease in the United States. Now, I don't think this is necessarily because we've gotten worse at treating COPD. We probably have more COPD related to smoking, but I actually think in part this relates to the fact that we've done a better job in treating cardiovascular disease, and people are living long enough to now die of their COPD. But at the same time, it also does reflect really a lack of investment into lung health, public health campaigns, or investments into understanding mechanism and treatment for chronic lung disease. So and unfortunately, this sort of lack of investment and in lack of awareness, it really spans pretty much every aspect of human health. It spans pharma investment, government investment, public health awareness campaigns, all of it. So this actually I pulled from a pharma investment report. And if you look at the top 25 diseases and the drugs under investigation for those diseases, you'll see cancer really tops the list. And at the bottom, you've got asthma, and almost at the very bottom, you have COPD. Now, why is this? We live in a capitalist society, right? So there are some things that are just simply easier to study. Diseases that are highly deadly and progress rapidly, like cancer, are much easier to study. You can get a critical endpoint for your trial in 3 months, be done, and return that money to your investors. Unfortunately, for diseases like COPD that are very heterogeneous, that take a long time to develop, you know, a lifetime in some instances, and are very slowly progressive. It can be really, really hard in a reasonable time frame when you've got investors breathing down your back to actually, you know, bring products to market. And so we've started to see pharma companies pull out of wanting to even do studies in lung disease. And so, for instance, and I think roflumilast, it's hard to even necessarily call that a new drug for COPD because it is a PDE4 inhibitor, and we've had theophylline for a long time. But if you look at the number of new classes of drugs approved for COPD in the last 2 years, it's really almost nothing. All we've done is just repackage, recombine existing classes of medications. And if you look at, again, at pharma spending in therapeutic areas, you'll see that respiratory disease is way, way, way down on the list. So that's kind of problem number one. But then you look at NIH funding. So NIH funding, not that there's some hard and fast rule, but generally speaking, funding follows the amount of disease burden in the US. And so there was this interesting graph that was published a couple of years ago where they looked at NIH spending versus US disease disability adjusted life years. And what you'll see is that there's sort of a general trend towards similar spending versus disease burden, but there are a couple of places where there are outliers. So where are the outliers? Well, one of the outliers, interestingly, is AIDS. And they actually have benefited from really aggressive campaigns and fundraising and going to Congress directly, and have really been arguably quite successful for improving funding for this disease. But what's on the other side of that line? You've got asthma here, and way down here COPD, and you've also got lung cancer. Part of the problem is that both COPD and lung cancer in particular are considered smoking-related lung diseases that carry a lot of stigma and pretty much no patient sympathy. I was joking with Vineet earlier when I was chatting with him in his office. I have a very difficult time fundraising for pulmonary. I don't get to pull the sympathy card that we do for pediatrics, for instance. So it's unfortunate. This really is not helpful for our investment to be swayed by things like this. Unfortunately, people blame a lot of patients with chronic lung disease for their problems. This is self-inflicted. Why should I bother? Why should I care? But unfortunately, this just really is not helpful from a public health perspective. One of the other challenges that we have is that COPD and a lot of chronic lung diseases really develop among those who are socioeconomically disadvantaged. If you think about it, this is, I mean, if you look at the green swath from Michigan down to Mississippi, this is Appalachia. This is where many of our patients with COPD are. They live in rural areas, that they're at the low end of the socioeconomic spectrum. They do not have good access to healthcare. And these are probably a group of individuals that are least likely to be able to advocate for themselves and advocate for their cause for increased spending. And so this really is just yet another factor in this problem. So how big is the problem? Well, we have roughly 30 million individuals with COPD in the US, and about half of those are undiagnosed. For people that carry a diagnosis of COPD, we only do spirometry to confirm the diagnosis in about a third of patients. So if you think about it, I mean, it's like admitting someone to the hospital for a hypertensive crisis, but never checking their blood pressure. But I'm going to prescribe some medication, and I'm not really ever going to check your blood pressure ever again. I'm just going to assume that that's what's wrong with you and send you on your way. And that's what we do with COPD all the time. One of the things that continues to frustrate me, and I think I'm on my third or fourth iteration of seeing this exact same document come out, the U.S. Preventive Services Task Force continues to come out and say, well, we should not do population-based screening for COPD. But it's important to remember that this is really based on lack of evidence, not negative evidence. It would just be a massive undertaking to try to get spirometry in a group of people and then follow them long enough to see if you've ultimately made a difference. The other challenge we have is Jeff mentioned I'm a member of GOLD. When GOLD first came out in about 20 years ago, in around 2000, the very first iteration of GOLD, they actually had this category that they don't claim anymore. It's called Gold Zero. And Gold Zero was sort of this at-risk group that was symptomatic that they thought would ultimately go on to develop COPD. Well, it turns out that symptoms are, unfortunately, again, not a very good predictor of picking out who's going to ultimately go on to develop COPD. So they ultimately got rid of the category altogether. But the problem, I think, is that just sort of, it's like out of sight, out of mind. And so now we don't bother screening for symptoms. Well, those don't matter. You know what, there's nothing I can even do for this disease anyway. So unless a patient's really complaining or they end up in the hospital, I'm just not going to bother. Since then, unfortunately, we found out a lot about the extent of disease, even among patients that don't currently meet our criteria for COPD. This is data from the COPD gene study, which is based out of National Jewish. But, one of the things that they've demonstrated is that there's actually a lot of disease, even among people that don't quite meet our current definition for COPD based on spirometry. There's air trapping and airway wall thickening and emphysema and all sorts of other abnormalities that just are flying under the radar right now. So when I told you that there was, 15 million people undiagnosed, the number of people that probably have some level of lung injury is even higher. This is a study that we did in the spiromics study, which is very similar to COPD. It's a large epidemiologic cohort where we've done imaging and pulmonary function testing. But one of the really interesting things that we found was that if you look at people in the red box who do not meet criteria for COPD, but you split them into high symptoms versus low symptoms, this is the high symptom group. If you look at the frequency of exacerbations, and you can look at almost any variation on that theme, whether it's treated with steroids, treated with antibiotics, treated with both, in the hospital, out, you can see that these people that don't even have COPD are having frequent exacerbation-like events. And actually, the number that they're having is not so dissimilar from symptomatic patients who meet our criteria for COPD, but we don't even know what to do for these patients. Well, these patients are all flying into the radar. They're not diagnosed, and we have very little data on how to treat these people or what to even do for them. So there's been a lot of discussion over the last few years about how do we even go about trying to identify these people. And one of the things that we've realized is as opposed to the old Gold Zero, we can't just focus on symptoms alone. We've got to look at other things. We have to look at CT abnormalities, such as structural abnormalities, other more subtle physiologic measurements. These are all things that potentially we need to be thinking about to try to define this at-risk group. But we really still are not at the point where we have any kind of widespread recommendation that's been adopted by the medical community for how to find these people. And we still, as I mentioned, certainly don't know, unfortunately, other than smoking cessation, what to do with them. So I told you we're kind of like on a thought journey with me. So we're going to fast forward now to January of 2022. And we're starting to see more and more data come to light about how people have been differentially impacted by COVID infections. One of the very first pulmonary patients that was hospitalized at the University of Michigan for COVID-19 was actually a lung transplant patient. He actually walked out of the hospital. I think knows what I'm talking about. Walked out of the hospital. And one of the things that really, really struck me is how is it that this lung transplant patient is walking out of the hospital? And I have 18-year-olds dying on the ventilator. Why is it? It was just a mystery for all of us. And I still think remains some of a mystery. But why do we see this heterogeneity of response to COVID-19? And I firmly believe, while this may not be the full explanation, I'm sure there are other immune factors and comorbidities that play into this. I am convinced that a certain amount of this heterogeneity that we saw in outcomes from COVID-19 infections is related to underlying undiagnosed lung disease. So one of the first pieces of evidence that I think points to that was this study, which just fascinated me. This was published in 2021. And it's not that it's the first time that we thought that there was a relationship between increased viral susceptibility and air pollution. But it was the first time that we had everything quantified and measured in such a direct way. So this was an epidemiologic study that was done in the American Northwest during the wildfires that followed that first summer of the pandemic. And they looked specifically at, for instance, areas of Northern California and Oregon that were really hard hit. They knew exactly where the air pollution was hitting. They knew when it was hitting. But at the same time, we had a virus that was being tracked like nothing ever before. And so we could actually look at the direct relationship between air pollution exposure and viral incidence and viral deaths. And what they found was that a daily increase in the PM 2.5 exposure was associated with roughly a 12% increase in COVID-19 cases and an 8% increase in COVID-19 deaths. And so for me, this was really, really fascinating because this is something I don't think, honestly, even I as a pulmonologist really ever thought about all that much before the pandemic. And that is the impact of the quality of air that we breathe, other things that are probably causing subtle amounts of inflammation, and how that might affect our susceptibility to things like respiratory viruses. The next piece of information that sort of adds to my thinking about this was a study that was actually published by the lung pathology group at the University of Michigan. And what they did was to look at open lung biopsies for patients with persistent ILD following recovery from acute COVID-19. And they looked at injury patterns, and for the non-pulmonologists in the room, usually the worst pattern that we see is usual interstitial pneumonia. That's sort of the most end-stage kind of fibrotic pattern that we can see under the microscope. And the very interesting thing that they found, though, was that for people that had the worst type of pathology on their biopsies, they actually went back and found that many of these patients actually had random CT scans that were done before they had gotten sick. And they found that those who ultimately had the worst findings on CT actually had ground glass opacities, interstitial thickening, peripheral reticulations, kind of subtle interstitial lung disease findings, well preceding ever contracting COVID-19. And so this just kind of goes along the same lines of sort of, in my mind, the evidence case for the fact that I really think that there are likely a lot of patients who have subtle underlying lung inflammation that contributed to the heterogeneity we saw with the COVID-19 pandemic. And really, to be honest, kind of frightens me when I think about it from a public health perspective about the number of people that probably have longstanding accumulating lung injury and we don't even know it. Why don't we know it? Because we never check pulmonary function testing ever. Now, even before the pandemic, there was this piece of information that had come out that to me really changed how I think about the development of chronic lung disease in adults. So essentially, this was a paper that was published by Peter Lange back in 2015 in the New England Journal. Because it's very difficult to get, a lot of lung function data. We don't just get it in kids. We have to rely on population-based studies. So for this particular analysis, they linked together a couple of population-based cohorts to look at lung function over the lifespan. And the really shocking thing that they found was that I'll do like a small aside here for a minute. I recently gave a lecture to our medical students and I said something about the Fletcher-Peto curve and they gave me blank stares. So I'm hoping I don't get blank stares about the Fletcher-Peto curve here. But the Fletcher-Peto curve, I think I'm still getting some blank stares. The Fletcher-Peto curve was something that I was taught in medical school. And this was the paradigm for how lung function declines in adulthood. And essentially the concept was that that everybody starts out adulthood with normal lung function, but when you're exposed to bad things like air pollution or smoke. I think that study actually had a lot of chimney sweeps in it, but then those people are the ones with the accelerated lung function decline, and that is how you get chronic lung disease in adulthood. But the fallacy in that thinking was the assumption that everybody makes it to adulthood with normal lung function. Now, why would we think that? Well, in retrospect, probably shouldn't have, we assumed, right? So, but we just almost never check it. So we made the assumption that everybody's getting to adulthood with normal lung function, and that's just how it happens. Well, in this study, one of the shocking things that they found was when you look at people who have COPD, half got there based on what I would call the Fletcher-Peto curve, the traditional line, the red line, where they had this normal lung function in adulthood, but they had accelerated lung function decline due to, exposures, et cetera, in adulthood. The shocking thing is that half of these people didn't follow that path. They actually had normal lung function loss in adulthood. Well, but why did they end up with COPD? Because they never had normal lung function in the first place. Half. So I told you earlier that we have roughly 30 million individuals in the United States with COPD. This data would suggest that half never hit peak normal lung function as a young adult, which suggests that there is something going on in a lot of people during a time in development when nobody's looking. So I had to put this cartoon in the talk. It was originally referenced by University of Colorado great Tom Petty. This is a cartoon that is, well, obviously we have almost no newspapers or cartoons, but back when we had newspapers and cartoons, this was a very well-known cartoon called Pogo. And it was about a little possum that lived in the Okefenokee swamp. And Dr. Petty pulled a quote from this cartoon and shared it in an editorial. And so the question is, I told you my original question, the question that I was seeking to answer is, how did we get here where we're at today? And he made the argument, well, we have met the enemy and he is us. So in this little cartoon, they're walking through the swamp and there's all sorts of trash, et cetera. And he's like, oh, his little buddy says, I hate walking on this hard stuff. And Pogo says, yep, son, we've met the enemy and he is us. So as a pulmonologist, what do I mean? Who's the enemy? Well, us, me. How is this problem my fault? Well, me, along with a lot of my colleagues, we love spirometry. We love really good spirometry. In fact, we'll get it done in a pulmonary function lab. You have to get lots of training to do it. You've got to repeat this measure 3 times before I'll take the best maneuver. And that data that comes out is great. It is very high quality. It's accurate. It's predictive of all sorts of lung diseases as well as mortality, et cetera. Think about how blood pressure is done. In theory, you're supposed to sit down in a quiet room. You're supposed to then, wait 10 minutes and you're supposed to get an average of 3 measures. Has anybody ever had their blood pressure taken that way? But you had your blood pressure taken. And I'll wager a lot of you even have a blood pressure cuff at home. How many of you had your lung function ever measured? I'll admit, I've only had mine done twice. Once as a pulmonary fellow, so I could kind of see. And then more recently, when I decided I actually needed a primary care physician. But that's another story. So this is the thing. We've so shrouded spirometry in mystery. We've made it this like it's got to be done so perfectly that perfect has become the enemy of good. And it's just not been widely adopted. It's not easy. And so for blood pressure, we no one measurement's probably all that good. But what do we do instead? We send patients home. We say, just use that cuff that you've got at home, but just write out all those measurements for me. And when you have 100 measurements to look at, you probably get close to bullseye, right? But for spirometry, we've expected it to be perfect. There's pros and cons to that approach, but the con is it just never got used. So now what? Here we are in 2023, and arguably we don't have nearly enough treatments for lung disease as I would like. We have lots of patients that are undiagnosed. What do we do now? So I do not pretend to have all of the answers, but what is clear to me is that if our goal is ultimately eradication of lung disease, if our goal is ultimately prevention of lung disease, we're going to have to start much earlier in the process than we have been. And it's going to take changes at the government level, public health measures, et cetera, because really lung disease starts in the womb. And there's all sorts of interesting data about exposures and how that can contribute to the development of lung disease in children. There's factors, not just things like secondhand smoke exposure in children, but also things like air pollution, respiratory infections, vaccinations, breastfeeding, et cetera, that ultimately all contribute to the development of health versus disease in adulthood. Even that term, lung health, that isn't even something we really talk about. It's not something that's really even been in our sort of common jargon. Now, heart health is, but we don't really talk about lung health. And again, I think part of the problem is we just never measure it, so we just don't know. So I kind of break, in my thinking about this, I kind of break up the lung health journey into three buckets: the prenatal, the development phase, and then what happens in adulthood. So I think we're all pretty much, well, pulmonologists anyway, are pretty aware of some of the important things that happen with lung development. In infants, lungs aren't even really fully formed by the time most children are born. And when we have more and more children that are born prematurely, this even further compounds the problem. So it's almost a race. And I honestly don't know where we're going to end up, because we've gotten better at keeping babies alive earlier and earlier, and we know more about how to protect them. But at the same time, babies are being born earlier and earlier as the technology advances. And so there may be more and more individuals that are now hitting adolescence, adulthood. And, it's interesting. I met one of these children in my clinic recently. He's now a young adult. And I always start every office visit. I don't care how old you are. I start every office visit with a birth history. So people do not always remember, but I ask, what can you tell me anything about, were you at term birth or were you not? Were you, were you on oxygen at birth? Anything weird happened? Did you refrigerated respiratory infections, asthma? Were you in the hospital or not? I had one of these cases walk into my office recently. He was an 18-year-old gentleman who, interestingly, was an OR scrub tech, but was noticing that he was having a hard time keeping up with his buddies on the basketball court. So I started talking to him. I said, well, tell me a little bit about growing up. He says, oh yeah, I was born premature, stuck in the hospital for a couple months, in and out of the hospital for the first couple years of life. He had just lost to follow-up, wasn't actively followed, maybe had one visit with the pulmonologist at one point, too young to get pulmonary function testing at that time, and just simply got lost to follow-up. When I measured his lung function, his FEV1 was around 50-something% predicted at age 18. And on top of that, a few years ago, he'd made the not so great decision to start vaping. Well, a lot of young people do now. And this is one of my arguments and the pushback against the sort of this U.S. Preventive Services Task Force stance on getting spirometry. They argue that as a clinician, there is nothing that I would do for that patient any differently, knowing whether they have COPD or not. But I would argue that people might make different life choices coming into adulthood if they know what their lung function actually is. And I would argue that this gentleman will be making different life choices now that he knows he's coming into adulthood with essentially 50% normal lung capacity. Now, there are all sorts of other things that can impact lung health. For instance, the whole problem of preterm births, shockingly, is actually somewhat high in the US when we compare it to other Western countries. This may relate to more use of IVF. It's hard to know, but our prenatal care here in the US is always coming under scrutiny. I learned some really interesting things about in utero nicotine exposure. So unfortunately, we still have a lot of in utero nicotine exposure. One of the interesting things is when mothers smoke, the nicotine, animal models suggest that the nicotine exposure itself actually causes the development of long and tortuous airways that would then predispose infants to the development of airflow obstruction. And there's studies suggesting it can lead to wheezing episodes in infants. Interestingly, there's also data to suggest that those negative effects from the tobacco smoke potentially can be combated by vitamin C supplementation. This is not something, honestly, as an adult adult physician that I was aware of, but it's really opened my eyes to the kinds of things that we need to be thinking about when we talk to our patients. We're also learning a lot about just the huge variation in what can happen with lung function during childhood. There are people that start off on supernormal courses that then level off. Other people start off low and then catch up. So it all suggests that what happens during childhood matters. There's things like breastfeeding that we know impact lung development, childhood immunizations, respiratory infections, et cetera. And so for me, it really heightens the importance of talking to parents about getting children appropriate vaccinations. Another thing I don't think that we think enough about, but I'm really, as the head of a lung division, thinking a lot more about the fact that we have to start getting much more involved in the air pollution space than we have in the past if we care about public health. And it's not just, sort of the traditional things that we think of. There are, there's indoor air pollution, there's outdoor air pollution. All over the news this year, gas stoves in homes. There's all sorts of risk factors out there that can contribute to poor lung development over the life course. Even things like where schools are built. So there's interesting data to suggest that when schools are near freeways, children have lower lung function, more asthma attacks, and when the children are moved out of those environments, the lung function and the asthma exacerbations actually improve. So when I said that the approach to fixing this problem is global, it really is global and even has to incorporate things like city planning. I mentioned indoor air pollution. So I've learned a lot over the last year or two about all of the threats in homes, from wood burning stoves, which have been associated with COPD, even in countries like Canada, with gas stoves, with VOC paints, and all sorts of things that we can do to educate our patients. Radon, which is the second leading cause of lung cancer, all sorts of things that we need to be aware of and advise our patients on improving air quality within the home. Unfortunately, we still have way too many children that are exposed to secondhand tobacco smoke. Roughly 40% of US children aged 3 to 11 are still exposed to secondhand smoke. And unfortunately, I started off this talk talking about the youth vaping crisis. Unfortunately, we sort of talk about the youth vaping crisis sort of went away, but the pandemic, the youth vaping crisis epidemic didn't go away with the pandemic. The problem is still here. We have roughly a quarter of our high school students who have used some form of electronic nicotine. And unfortunately, the FDA has been really, really slow to regulate this space. I'm going to show you, and I can't remember if it's this slide or next one, but there is some data that we're accumulating in some of the new NIH-funded studies that we've been doing on young people. And I'm really shocked about the burden of lung inflammation among individuals we would normally never get CAT scans on. So what about adulthood? This is the space where we're, I think, a little bit more used to, but I think the mindset that we have to get out of is traditionally COPD has been thought of as a tobacco-related disease, and I'm not saying that still isn't a huge contributor, but we have to be aware of all the other things that adults are exposed to in terms of occupational exposures, and not even just the traditionally dusty, dirty jobs like construction or working in a manufacturing plant. That might even be your hairdresser or a nail tech, et cetera. There are all sorts of really harmful chemicals in the workplace that can ultimately impact lung health. So this is these are screenshots from patients at the University of Michigan. We have been doing 2 studies that I know are being done also here in Colorado, but one of those studies is a study that's just been funded by the American Lung Association to look at 25 to 35-year-olds with CT scans and lung function, just community dwelling adults. And then we have a second study, the SOURCE study that's been funded by the NIH to look at 35 to 50-year-old smokers. And what has been really interesting and shocking to me is the number. I was doing it yesterday for 3 or 4 hours. It's my constant daily work, and that is we get probably 5 to 10 scans a week, and I'm on the phone constantly calling these patients to say, guess what? You've got some inflammation on your CT scan. So let's talk about what you're doing and what we need to do to improve that. And it's really shocking. I mean, yes, some of it's tobacco, but I'm also getting marijuana, I'm getting vaping. It's clear that there's lung inflammation and lung damage. Now, what that's going to look like in 10, 15, 20 years, I don't know yet. But it's clear to me as a pulmonologist that there are abnormalities there. And I just grabbed some screenshots here of some of the things that I'm seeing, including early emphysema, gas trapping on expiratory scans, and then a lot of patients. This honestly is probably the most common finding are central lobular ground glass nodules that look like some form of respiratory bronchiolitis that when I trained, we were taught was pretty much solely associated with tobacco exposure. And now I'm seeing that it's associated with a lot more. So I spent the majority of this talk talking about defensive strategies. We have to, protect the lungs that get this, protect the lungs that get this, et cetera, infections, air pollution, et cetera. Is there anything to suggest that there are offensive strategies, anything that would actually be protective for lung health? Well, I think one of the best pieces of data for this actually comes from a colleague of mine, Robbie Callahan at Northwestern, and this was a study that a lung study that he did as an add-on to a heart study, Cardia. That's just sort of the theme for the day anyway. But Cardia had the money, and he tacked on a small lung function study onto the Cardia study. And but what he found was it was really, really interesting. So they followed adults, I think, from like 35 to 55. And they had data on lung function at the beginning and at the end, and they also had some exercise testing data. And essentially what they found was that higher baseline fitness levels were associated with higher lung function at baseline, as well as higher lung function later on in life. And if you maintained or increased your fitness levels, then actually those are the people that had the absolute best lung function later on in life. Now, you could argue, okay, these are exercisers, they've got stronger respiratory muscles, that explains the improvement in lung function. And that could be the case. I can't tell you that it's not, but there are definitely some thoughts that it could also be some of the anti-inflammatory effects. We know that exercise boosts the immune system. There's all sorts of positive effects from exercise, and it could be that exercise is actually decreasing inflammation and helping the lungs through a completely separate mechanism. And I think this is the kind of data that's really exciting. I think we need more data on this and nutrition and all sorts of other offensive strategies, but it does just kind of widen the scope for how we can help our patients have the best lung health possible. So, in closing, this is sort of the closing statement in my book, but I think it kind of wraps up my thinking for this talk, and that is that we really, I think, as a medical community, have to begin recognizing the warning signs of lung injury much, much earlier than we have been, and that spirometry is ultimately a test, not just a test of lung health, but rather human health, and we have to think about it as the fifth vital sign. So, thank you.
Dr. Hahn, thank you. That was wonderful. I will throw it open to the room for questions. It's back to Dr. Gray.
Great talk. One of the things I'm interested in is the change from looking at percent predicted of FEV1 and FVC to the Z scores. Do you think that will be better at helping us understand who has lung disease and how severe it is, and helping us think more about how to help care for these people?
This is such a huge, sticky, messy, ugly, gnarly problem right now. So the problem is that we have had, like race, height, age adjusted equations for years, and now we don't know what to do. It is like an endless loop of nobody can find their way out of the bucket, because the problem is that when you look at certain people that live in certain regions or have been exposed to certain things, whether that's race or just even geography, they're all going to have been influenced by whatever air pollution, nutrition, socioeconomic factors ultimately impacted their lung development. And so nobody can figure out what normal is. Like, we just can't figure it out. And, you know, I'm one of the deputy editors for our major journal. And for some reason, our chief editor seems to send all these papers to me. And there's just paper after paper coming in with, like, we have to do this, we have to do that. I wish I had a really good answer for you, and I don't. But it's being looked at really heavily by the community, and whether we should, you know, I think most people are moving away from looking at race, but then how do we figure out exactly what, you know, what normal is? You know, do we do, you know, arm span? You know, it's a really, really sticky problem, and I don't have some really great answer for you. But what I will say is this: if we were talking about something like prostate biopsies or PSA and mammography, what's the worst that could happen? Okay, well, someone might get an unnecessary biopsy. Somebody might get unnecessary surgery. It might be, you know, that's kind of what we're talking about. For this, like, okay, maybe they'll get, get us, you know, a CT scan. Maybe we'll just keep an eye on them a little bit longer. Maybe we'll bring them back for lung function in a couple of years. So I don't actually think anything like truly bad is going to happen from potentially overcalling. We have a lot of arguments about what do we do, and is the mental and emotional impact of calling more people that have COPD than maybe don't. I ultimately don't know, but I think ultimately, you know, for some of these patients that are kind of borderline or might hit it by one criteria or another, I'm just, you know, following these people, and, you know, whatever that imperfect metric is that you've got, you just get it the next year, and then, you know, you get it in a couple of years, and maybe I'll get a CT scan. And ultimately, I think if those patients do have a progressive disease, it will, you know, manifest. So I don't have it's a great question. I have no good answer for it. But I still think there's, you know, value in taking whatever measure that is, being aware, getting it, and following it over time if you're at all concerned.
Chris?
So wonderful, sort of walking through everything for some of us that don't deal with lungs all the time. And I think you made a very compelling population health argument here. To what extent is, so as such, it sounds like it's much more beyond, it has to include people outside of the medical realm as well, is what I want to say. And to what extent have pulmonologists and the lung injury community been involved in things like urban planning? You brought up wildfire, all of this sort of preventive management of how we live. It seems like that's where we need to be going as well. And I don't know to the extent that we already are.
Yeah, I think some of us are becoming more aware. I don't think we've done enough. And I think I do think it's both. You're right. It's both on the population level as well as at the patient level. Like me in the office, I need to be much more aware. I need to convince my colleagues to have a much lower threshold, you know, for screening. But then you're right, at the kind of global level. Groups like the American Thoracic Society, American Lung Association are trying. I've tried to make as much noise as possible. I wrote an editorial in the LA Times. One of the things that I've multiple letters to senators, government agencies. I was pretty appalled, honestly, when they were putting together the so coming out of the pandemic, there's all these pandemic preparedness groups. None of them had any thinking about, respiratory health, forget ventilators. I mean, that's kind of a solvable problem, but just thinking about, more investment for treating and coming up with cures for ARDS, et cetera. There's been very, very little. So it's interesting, in the news this last year, gas stoves, but that gas stove information was published years ago. We've known this for years. It's just now kind of finally making some noise. So I'm hopeful, I think that, that we probably can make more traction, as an entire medical community, but I think there's a lot more that needs to be done.
Dr. Bull?
Great talk, and yeah, thanks for that walk down history to where we are here today. So you started off with the idea that the COVID pandemic really all of a sudden brought attention to lungs in general, and then sort of then mentioned that, but pharma seems uninterested in putting money towards this. Though the example of it being COPD being a long disease, it takes a while to ultimately get to endpoints. But ARDS is a pretty short lived with a defined mortality somewhere between 16 to 32%, depending on how they're managed. And yet still basically what we do is we try to minimize the damage we do with the ventilator and maybe dry out the lungs with suboptimal evidence for that even at that point. I mean, the ventilator, sure, the drying out a little more difficult. So so it seems like a ripe for study, ripe for target. What are your thoughts on why that hasn't been?
Yeah.
Insurance comes to mind as or the uninsured as an issue. But.
I mean, I do, in complete transparency, work with a lot of pharma companies, so I shouldn't completely throw them under the bus. But I think for the chronic diseases, they have invested, and there's a lot of failed studies. There's like a graveyard of failed studies. And I think because they're expensive and long, we're talking, $100 billion down the tubes when they have a failed study, that it's just a graveyard. And so I think the part of the problem for a lot of the adult lung diseases is they're very heterogeneous, right? So I even showed you that, half the people are sort of on that downward trajectory. The other half that probably something happened in childhood, we're probably not going to be able to help those people, but they're all in clinical trials, because right now I can't tell the difference between the people I'm going to be able to help and the people that I may not be able to help. So that's part of the problem. I think on the inpatient side, I think those are also really challenging studies to do. I stepped out of my normal lane, and I was actually the PI for a COVID ARDS study during the pandemic. And it was clear to me in working with the pharma company that I worked with, they had never done studies like this. It wasn't that they didn't want to help. It wasn't that but they just didn't really have much expertise in setting up the study, what endpoints to look at. And ultimately, that study unfortunately was negative. It probably could have been designed better. Part of it was probably my fault, but I think I think they're just really scared when you don't have a clear development pathway. ARDS, again, is very heterogeneous. It may be that the drug helps people with infectious ARDS versus non-infectious ARDS. We found, during that trial, it was so messy. Like, if you want to say going to the ICU is an endpoint, the definition of ICU and why a person might end up in the ICU varies not just from country to country, it varies across the street, across the floor. So I think that there's just many, many things about these studies that make them messy and high risk. So that, that's a little bit of a separate problem as well, which is why I think they're actually, this would be a whole separate talk, but I think one of the problems is I think the FDA needs to really, particularly the pulmonary branch of the FDA has just been really, really rigid about what they'd be willing to look at and accept, and very generally difficult to work with. The other groups will take an endpoint that the pulmonary branch is absolutely unwilling to accept. And so I think that there has to be a little bit more recognition of, we all need to be on the same page. We have a real problem, and we're all going to have to kind of work together to try to figure out how to design these studies so that they're feasible, don't break the bank, and people are actually willing to dip a toe in. I will say, I think, like everything, the pendulum always swings. And before the pandemic, I was just really, really unoptimistic. I would say, particularly with the advent of biologics, there was actually just a study published this week about a second positive study for a biologic in COPD. So I do think that the pendulum is starting to swing back a bit, but I think, again, just to the extent that I can kind of rattle the cages, I think it does really require some government and FDA buy-in to figure out how we can make people more interested, more excited, feel like it's worth the investment to jump back into these waters.
We have time for one last question, Dr. Badish.
Thanks. That was a great talk. In the pulmonary hypertension clinic, we're seeing patients now with combined pulmonary vascular disease and airways disease without obvious risk factors. They often have a history of prematurity. And so I just wanted to second again your recommendation at taking a careful birth history. It's really important.
That's really interesting. Thanks for
Thank
sharing.
you. Very nice talk. Yeah.
All right, and we're right at 1 o'clock, so we will call it. And Dr. Hahn, thank you very much for doing this.
Yeah.
Appreciate it.